Hello again, everybody. This is Alex McDevitt with the RHSC Secretariat. We're going to get started as we have a very packed agenda today for this Safe Abortion Supplies Workstream Webinar on how to talk about abortion. Just a few logistics pieces. All participants are automatically on mute. We will have time at the end for discussion and question and answer, and to participate in that, there is a questions box where you can type in your questions, and we will get to them in the order that they come. Today we'll be hearing from a whole host of excellent speakers. We have Sarah Shaw from Marie Stopes International, Hadassah Washman from IPPF, Chris Hammond from Ipas, and John Townsend from Population Council, who is the chair of the RHSC, as well as our co-chairs of the Safe Abortion Supplies Workstream, Natalie Kapp and Jennifer Blum. So to begin, I'll turn it over to John Townsend to give us an introduction.
Thank you, Alex. It's a pleasure to be with everyone today. The Reproductive Health Supplies Coalition is the largest organization of supply-focused in the reproductive health area, and it works across the entire gamut of reproductive health supplies, from menstrual hygiene products through to long-acting and reversible contraception. The Safe Abortion Workstream is really the newest workstream within the organization. It was formed about 2 years ago, following demands and interests, I think, of membership organizations and governments that cooperate with us. It was the specific proposal of the government of Norway and the foreign minister there that wanted us to address this issue. Safe abortion is both a right in itself and as part of an array of reproductive health services, preserves the health of mothers and protects the right, their decision to make the decision on the number and timing of their children. We know that public opinion globally is mixed on this theme, but we also know that kind of policy and public opinion is more favorable if the issue is placed around protecting the health of the mother. In cases of rape and incest, for example, it's quite common for countries to allow abortion under those conditions, and it's even more favorable in terms of public opinion if it talks about the health and welfare of the mother and preserving family, and that's a big issue. We also know that members of virtually all faith traditions practice abortion in one way or another, sometimes legal, sometimes unsafe, sometimes highly stigmatized. It is very private in nature, but it is something that the World Health Organization, the African Union, and many gynecological associations and nurse midwives associations around the world support in principle, and to ensure welfare of mothers. There is a lot of misinformation, myths, and misconceptions around the theme in terms of its timing, actually how the procedure is done, what are the risks, what are the legal or physical consequences for the mother, the provider, how does it affect fertility post-abortion. So we need more straight talk about the meaning of abortion, how it's framed, and essentially how the quality of care is thought about and what the different products are and services. We know it's done through DNC, manual vacuum aspiration, medical abortion, and it's an issue that I think this webinar will provide a great deal of additional information. One thing we are clear about: it's not rare. Globally, about 25% of all pregnancies end in abortion or miscarriage, and we know that the legal status of abortion actually has no effect on how many abortions are done in any given country or where they're done. We do know that there's a range of legal contexts, and we'll hear about that later. But I think the most important thing is how in the supplies area are we thinking about this in a way to preserve and protect health, so that the services available to women in wealthy countries or in wealthy segments of a given country aren't the only ones who benefit from this critical maternal health service. So back to you, Alex. Thank you very much. Looking forward to the discussion.
Great, and now I will turn it over to Sarah Shaw from Restopes.
Great, thank you, John, and thank you, Alex. So if we move to the slides that begin with global trends, that's it. So nearly half of the abortions globally are unsafe, and an unsafe abortion means that they take place without one or more of the following elements. So it means that they maybe aren't using a WHO recommended method of abortion, they maybe don't have the support of a trained provider, or they take place in an environment that's lacking in the minimal clinical standards. Globally, around 20% of the burden of maternal mortality is due to unsafe abortion. So by eliminating unsafe abortion, we could reduce global maternal mortality by a fifth. In some countries, this is much higher. So, for example, in Nigeria, it's estimated that the impact of unsafe abortion on maternal mortality is in fact around 40%, so nearly half. Next slide, please. And as you can see, the incidence has always been there. There's not a huge amount of variation going back from the early 90s. The reason why there has been an increase in recent years is because women's fertility desires have changed. A growing proportion of pregnancies are ending in abortion because women are increasingly seeking to delay or limit childbearing, but they don't have access to the information, the services, or the supplies that they need to actually take action on that desire. Next slide, please. You can go to the next one. Thank you. So, looking at the legal status of abortion, this map is produced annually by the Centre for Reproductive Rights, and it gives a RAG rating for the world. So the countries that are in red are countries where abortion is permitted under just one indication to save a woman's life, or is prohibited altogether. Amber countries, abortion is permitted under a couple of indications, and then green, abortion services are permitted without restriction. The cream countries are those where it's permitted for socioeconomic reasons. And as you can see, there's enough countries with red, but there's quite a lot of variation across each region. I think at this point it's probably worth pointing out that good laws don't necessarily mean good access. So for example, Zambia, great law on paper, but in practice it's actually really hard to find the right number of providers who will give you the permissions and so on. So what does that map mean in practice? Well, abortion is only completely prohibited, so completely illegal in 4 countries. And they are Vatican City, Malta, El Salvador and Nicaragua. So that means that, over 190 countries in the world permit abortion under at least one indication. Post-abortion care is recognised as an emergency intervention to reduce maternal mortality. And there's global consensus from WHO and across a number of other norm-setting bodies that this is an acceptable emergency treatment and is permitted everywhere. The reason, in the 190 countries where abortion is permitted under at least one indication, it's quite likely that women are not able to exercise that indication, and that's for a number of reasons. It could be that women aren't aware of their rights and entitlements or aren't empowered to access them. There could be health system barriers, such as the providers aren't trained, or there aren't the necessary medical supplies or equipment. And also barriers such as stigma, fear and perceived restrictions. If something's perceived to be illegal, women are reluctant to access that service, and providers are often scared to provide the service. Next slide, please. So restrictions don't reduce abortion, they just make it unsafe. As you can see, there's not actually a huge amount of variation between the rate of safe and unsafe the rate of abortion in countries where abortion's highly restricted is around about the same as the rate in countries where abortion is much less restricted. Next slide, please. And as you can see, the restrictions don't reduce abortion, they just make it unsafe. And it's at this point, it's important to point out as well that the burden of unsafe abortion is usually carried by poor and marginalised women and young women. So those that live in remote rural areas, they can't afford to travel to get services, or they can't afford to pay for services. Next slide, please. Okay, you can go on to the next one. So, thank you. We're going to have a look at abortion stigma, because stigma is a huge barrier to women accessing services, and also a huge barrier to policymakers to make the policy that's required to ensure that there's access and that the abortion supplies are there. Stigma exists at many different levels. You know, at the individual level, the perception of a woman that she can't access services is a barrier. At the community level, the attitude towards community members towards services or abortion supplies can particularly block access. So, you know, if a community in a small drug shop maybe would feel that they're not able to stock medical abortion products through fear of pushback from the community. At the institutional level, we see blocks within the health system to accessing safe abortion. And, you know, these blocks can be things like that they're not prioritising the forecasting and procurement of abortion supplies, or they could have something to do with the, you know, the pricing of services, or restrictions around the type of facility that can provide the services. Often abortion and post-abortion care services are only available at high-level health facilities, which for rural women who maybe don't have access to a district level hospital, or it's a long way away and expensive to get to, that's a huge barrier. Obviously there's laws and policies that don't prioritise access to abortion products, which limits access. And then also the way in which the media reports on abortion, as long as the media reports on you know, using stigmatising language and maybe stigmatising the woman and the provider, there's a reluctance to talk about it, and then there's a reluctance to address these barriers. I'm now going to turn over to Hadassah.
Hi there, thanks Sarah. Yeah, so just sort of following on from what you are saying around sort of stigma and messaging, and obviously you're talking about how the media report on abortion, but we also know that a lot of the organisations that are working on abortion themselves can sometimes use stigmatizing language themselves. And, you know, we know communication around abortion can be difficult and complex. But, you know, we created, IPPF created a guide on how to talk about abortion to try and help organizations that are working in and around abortion, to help them create and design either new materials or review their current materials to ensure that they have sort of removed any stigmatizing language or stigmatizing images. So obviously our guides are available online, but I thought I would pick out a few key things which we can go over here. So some of that is the golden rules of abortion messaging. So looking at being honest and accurate, so we understand that all messaging should be accurate, while some we know struggle with like the decision to end a pregnancy. We also know that relief is a very common emotion. Recognizing its common occurrence and focusing on the realities of abortion can help counteract, we feel like it can help counteract stigma. Obviously being non-judgmental, all individuals having the right to make decisions about their own bodies, meaning that no one abortion is more justified than another. Ensuring that all of our material is focused on the individual and the health of the rights of the pregnant woman in all messaging. Recognizing diversity, so again understanding that no two abortions are the same and that they can come from different socioeconomic and cultural settings and affect a wide range of people. So when you're creating any communication or messaging materials, make sure that you're presenting a wide range of experiences. Avoiding stigmatizing languages and images, which we've got a whole section in our messaging guide, which includes specific images and has a table of stigmatizing language, which I've sort of cut some key words from, you'll see in a few slides, but just again making sure that the language is appropriate. Involve the intended audience as much as possible in the development of communication materials. So by that, I think we mean if your communication materials or your messaging materials are supposed to be focused on young people, involve them in the conceptual design stage if possible, or at minimum, they should be tested with the intended audience. And lastly, we've got always provide references and resources. So as well as giving citations for factual information, communication materials about abortion should also give the opportunity to audiences to obtain further information about abortion-related services should they require it. Next slide, please. So within this is sort of like a little table. So you can understand we have these checklists which we've designed to provide sort of practical suggestions for things to consider when developing or reviewing resources on abortion. So again, they include a variety of different things, and this will be relevant. Each checklist will be relevant depending on the type of resource that you're creating and the purpose for it. So for example, including personal stories about abortion will be particularly important for materials, which are designed to persuade or engage with an audience, such as a blog post or an article, and using sort of accurate statistics and legal facts will be more relevant for materials which are designed to inform and to educate, such as training guides or press releases. So, I'm not going to go through them all now, but this list, the checklist in the guide sort of goes through, and you can have a think about who you are creating your communication or your messaging materials for, and make sure that you sort of go through these checklists and that the information is relevant. Next slide, please. So this is just an example of some of the terms we've included in our messaging guide in the stigma-free language section. So you've got examples such as, avoiding terms such as abort a child or abortion is illegal. As Sarah mentioned before, abortion is illegal completely in only 4 countries. So we would try to avoid starting on a negative and sort of say instead abortion is legal under the following conditions, or it's legally restricted. And then things like we would avoid the word mother, rather use pregnant woman, and things like repeat abortion or multiple abortion. Multiple and repeat can have sort of negative connotations, such as, I'm thinking about repeat offenders. And it also implies that each abortion experience for one woman might be the same, whereas we understand that each abortion experience is made in a unique set of circumstances, so we would rather use something like more than one abortion. And again, with late-term abortion, late could refer to any time in the 2nd or 3rd trimester, so it's not clear what you're talking to or you're referring to when you're using the term late-term. So we would say, again, abortion in the 2nd or the 3rd trimester, so we would be a little bit more specific. So those are some examples. There's a whole list of them in the messaging guide, and please, I still use my messaging guide when creating materials just to make sure that all the language that I'm using is appropriate. And I know, even some of us who have been working in this field for a long time, we can often just, forget how sometimes things can be read or misinterpreted. Next slide. So these are just some of the resources, not all of them IPPF, but we've got the messaging guide, which is what I've been talking about. We've got IPPF's guide on how to educate about abortion, which was developed for trainers and educators who want to deliver workshops or trainings on abortion to young people. specifically, but these sessions can be relevant for anyone. And then we've got How to Report on Abortion, which was produced by IPPF and the International Campaign for Women's Right to Safe Abortion. And again, it's been written for those working in the media to encourage sort of accurate reporting of the facts about abortion and honest portrayals of abortion as part of people's lives. And then we've got Ipas's Abortion Attitude Transformation, which I know that someone from Ipas is on the call after this and might be able to say a bit more about it, but it's a resource for trainers and program managers, technical people who organize or facilitate training events around abortion, and it provides sort of some clarification, key skills for global audiences. And that is it from me.
Great, thanks, Hadassah. So if you can move on to the next slide, thank you. So now I'm going to have a bit of a deeper dive into abortion-related supplies and the map of misoprostol registrations all over the world. A huge amount of work has been done to get MISO registered, and it's been really successful work. In countries where abortion is highly restricted or only permitted under very limited indications, MISO has been registered for things like postpartum hemorrhaging, post-abortion care, just in the health system. And if we move on to the next slide, please. Then looking at mifepristone approvals, which is, this is really the next big milestone in increasing access to abortion-related supplies. There's still all the grey areas of countries that haven't yet registered MIFI, and there's still a huge amount of advocacy work to be done to get, not only to get MIFI registered, but once it's registered, to get it on the National Essential Drugs list, because then it's more likely to be prioritised for procurement. And if we move on to the final slide, please. So what can we do as the Reproductive Health Supplies Coalition? Well, a quick checklist of things that we can advocate for is, has MISO and MIFI been, Combipac been registered in your country? Even in restricted settings, you can maybe use indications such as postpartum hemorrhaging or post-abortion care or EC, just to get it on the list, just to get it registered and get it into the health system. Are these products on the essential drugs list, or in the case of MVA, are they on the National Essential Equipment lists, and are they part of procurement plans, so are they actually being procured? And then work around high quality and affordable generics. These are products which are in generic production, and that can bring the price down and make them more accessible. So that's all from me. Thank you very much.
Hi, everyone. This is Chris Hammond. I am the Senior Technical Advisor for Supply Chain Management here at Ipas. Today I'm going to be sharing some lessons learned from our work in Pakistan, where we were successful in increasing the availability of abortion commodities by changing how we talk about abortion. I want to quickly mention that my colleague from Ipas Pakistan, Dr. Ghulam Shabir, who's our country director there, is also on this call and has graciously allowed me to speak on the team's behalf this morning. Really quickly, before I dive in, just for those who might not know us really well, Ipas is an NGO working globally to increase women's ability to exercise their sexual and reproductive rights and to reduce deaths and injuries from unsafe abortion. Here at Ipas, we believe that every woman has the right to the highest attainable standard of health, to safe reproductive choices, and to high quality care. So in a restrictive legal setting for abortion, such as Pakistan, Ipas and our partners were successful in influencing political norms before any formal change in the country's laws, primarily by shifting the narrative from abortion provision to addressing maternal mortality by improving access to safe abortion within the parameters of the law there. So by focusing on improving access to safe abortion as a way to address maternal mortality, we were able to approach abortion provision through a more pragmatic and health-oriented process. Another approach in talking about abortion provision in Pakistan was to present the issue in terms of providing post-abortion care, which was already included in the work of Pakistan's Health Department of Emergency Obstetrics Care. Our focus during different meetings and conversations in Pakistan has been on maternal death and the negative health impacts associated with unsafe abortions, as well as its burden on health systems. This focus really helped guide stakeholders to look beyond pregnancy termination and the socio-political stigma that it invokes. Next slide, please. For Ipas in Pakistan, the key to making progress on a politically sensitive and stigmatized issue like abortion was really desensitizing others to the topic through continuous conversations with a broad range of stakeholders. So the establishment of the Pakistan Alliance for Post-Abortion Care was a fundamental step in gathering the voices of like-minded private sector organizations in a strategic advisory and advocacy forum. Two other close partners of ours in Pakistan are the Midwifery Association of Pakistan and the Society of Obstetricians and Gynecologists of Pakistan. Their opinions, public statements, and advocacy initiatives really are an influencing force on the policy actions of ministry officials. My colleagues in Pakistan have worked very closely with both of these groups to educate its members about existing abortion laws. We've conducted values clarification trainings using the guide that was mentioned in the previous presentation, and have worked on building consensus around the importance of access to safe abortion in order to reduce maternal mortality. And a direct result of this work was a statement that was released by the SOGP on the need for incorporating safe UE methods in different training curriculums, and more specifically, the inclusion of misoprostol and MVA in the national midwifery curriculum. Next slide, please. Our work in Pakistan began in the Punjab province, which is the province with the highest population in the country. There we hosted different meetings with key provincial stakeholders and discussed the impact of unsafe abortion on women and girls, and worked together to identify a common solution for mitigating this impact by recommending the use of manual vacuum aspiration. In order to achieve this, we really relied both on international and local evidence as well as technical assistance. And these were our main advocacy tools bringing about this change. So these different efforts ultimately led the Punjab government to establish the Punjab Reproductive Health Technology Assessment Committee. And this committee was quite receptive to the evidence that was provided for safe UE technology, and eventually included misoprostol and MVA in the essential package of health services and essential supplies lists as the technology of choice for providing safe UE and post-abortion care. All these efforts in the province culminated in April 2015 when members developed and adapted the Punjab standards and guidelines for high quality, safe uterine evacuation and post-abortion care. Next slide, please. Implementing these policy changes required some programmatic interventions around capacity building, especially with mid-level providers in the use of misoprostol and MVA for UE and PAC, but also for bringing about commodity sustainability. Social marketing organizations like DKT and Green Star Social Marketing each played a pivotal role in creating an effective supply chain by serving as reliable commodity sources. In order to ensure long-term sustainability of MVA and MISO, Ipas Pakistan trained district health managers, providers, and other relevant staff on how to use Ipas's commodity forecasting tools, such as the MVA and MA calculators, which are online tools that use caseload data to forecast a facility's commodity needs. So the success of these different policy initiatives and programmatic interventions meant that this approach could be replicated in other provinces And so Ipas and our partners in the country began working in Pakistan's Sindh province, which is the country's second most populous province. And we really followed a similar approach there. So the Sindh Reproductive Health Technologies Assessment Committee was formed, and they adopted and implemented the same standards and guidelines that had been developed and endorsed by the Punjab Department of Health. Next slide, please. So with the track record of successful interventions in 2 provinces, Ipas Pakistan attempted to increase the impact of our work by shifting our focus from a provincial level to the national level. So we started by advocating with the Pakistan Ministry of Health for the endorsement of a woman-centered post-abortion care manual, which is now used as the national standard document for trainings on the topic. Our advocacy work with the Drug Regulatory Authority of Pakistan resulted in the inclusion of misoprostol in the National Essential Medicine List for uterine evacuation and post-abortion care. And still in line with scaling up efforts to the national level, Ipas and our partners in Pakistan used the same Punjab approved treatment standards and guidelines as a starting point to develop national level guidelines, which were approved and endorsed by the MOH. And so all this work has really created an environment and provided an opportunity for various organizations working in abortion and post-abortion care in Pakistan to take these standards and guidelines and implement them in new provinces or regions in the country. As a final point, I just want to recommend that if you're interested in learning more about the really excellent work that the team in Pakistan has been doing, you can access this article that's referenced here for a much more detailed synopsis of our work there. And that is it from me. Thank you.
Great,
thank you, Chris.
so much. And
Alex, would you like me to move on to the question and answer? Okay, for sure. So first of all, I'd like to thank all of the speakers for those great presentations and a lot to think about, and pointing us to a lot of resources that we can be using for our work. Before moving into the question and answer period, we did want to give an opportunity for Nandini Archer from the Campaign for Women's Rights to just say a few words, and I'm just going to go now and I have to mute. Alex, do you see her as an attendee?
Yeah, no, I don't see Nandini's name on the list.
Okay.
She may have some trouble connecting, but it doesn't look like she's.
Okay. Okay, I don't as well. Well, then we will hold that for later, and then I can just open it up. So the way that we will do this, if people can type in their questions, then I will unmute you and read the questions, and we will have an opportunity to have them answered by some of our speakers. It's harder to navigate than I thought. Sarah has asked, will we get a copy of the slides? And I can answer that already because we spoke about that before the call. Alex is going to put all of the slides together in a PDF and make them available to everybody who's a part of the work stream. So that question is answered. There's an additional question. I'm going to unmute you, Sarah. You asked, it is not possible to read slide 13, the approach in Pakistan. The health approach does not focus on stigma reduction. How do you see this? Would a stigma reduction approach be possible? Okay, and so that is a question for, I guess, it's very hard to read. That would be a question for the for Ipas Pakistan to answer. Are you unmuted, or do I have to unmute you?
Hi, this is Chris from Ipas. Dr. Shabir, I see you're online. I'm going to unmute you in case you wanted to answer that question. He Dr. Shabir, if you want to unmute yourself, go right ahead and jump in. I can quickly just say that a lot of work was done around reducing stigma associated with abortion provision, and it was really by changing the way we talk about abortion, and instead of focusing on abortion provision as its own topic, we really wanted to address maternal mortality and post-abortion care as the main driver of the conversation in our work there. Dr. Shabir, I see that you're unmuted now. Is there anything you'd like to add?
Yeah, I think, thank you very much. It's a great opportunity to be part of this discussion forum. So in Pakistan context, I think the stigma is prevailing everywhere, starting from the policy level to the community level, healthcare providers, healthcare institutions. I think the most important thing which we had been able to mobilize the relevant stakeholders and then bring one voice at national level and provincial level was that sharing the evidence from our National Population Council study, which came in 2012-13. There was a high incidence of induced abortion of 2.2 million per year. So that was the opening point with the policymakers and relevant stakeholders, and that actually became the evidence opening for the evidence-based advocacy. So in fact, dilemma is that whenever we started talking with the policymakers or healthcare institutions, the stigma was there. So to open up our discussions initially, we brought in few champions, healthcare providers who have been providing services to the women who are coming to them in the rural areas or at the secondary level hospitals, particularly the mid-level providers. And they shared their examples or experiences from the rural area, that how or in which stage the women are coming to them when they have the abortion in the back streets and because of the restrictive environment, and then they are coming with complications, because the study also reported that 700,000 complications are reported every year after this 2.2 million induced abortion. So important thing was that how to control this the increased number of complications, and for that the important thing is that we basically have to shift our approach from unsafe technologies to to the safe technologies. So it was just with the misoprostol and MVA from DNC. The DNC is the commonly used method. Like 69% providers prefer to use DNC in Pakistan still, despite many of the trainings are happening. So important thing is that the endorsement we got from the provincial level, that was the highest level, by sharing this evidence, and then which has scaled up to the national level. There is a document which has been in agreement by all the stakeholders, where we have to introduce the standards and guidelines at provincial level and at the national level. So that became the basis to start the trainings where DNC is being practiced. So that was one of the things that we started from tertiary hospitals and now trickling down to secondary and primary level hospitals. Where we started the training, the DNC was gradually switched over to misoprostol and MVA. So it's quite right that post-abortion care is already part of emergency obstetric care. But when we mobilize the community-based lady health workers, which is like more than 110,000 in Pakistan, with the messages on safe pathways, that what are the actually pathways where they have to refer the women, if the women are coming to the rural community-based lady health workers, the most important thing is that they have to refer to the safe providers who are the trained providers. So they were able to link those or refer those women to the trained providers. And first, I think important thing was that the complications were being managed by those trained providers at the public sector facilities. And when that door was opened, we have actually analyzed the data which is coming from these facilities where IPAS is training, that 70% is post-abortion care and 30% is the induced abortion which are being managed by these safe trained providers. So it is all due to the endorsement by the national and provincial level, senior level policymakers that has been able to bring down stigma to some extent, that when the lady health workers are referring the cases to the facility for post-abortion care, there is now acceptance to some extent that women who are directly approaching these safe providers, they have started providing the safe abortion care also. It's a long way to go, but probably this national standard and guideline and broadening up the use of misoprostol for PAC indication, and particularly replacing the abortion word with uterine evacuation. It's a medical terminology, but that has been absorbed well by the healthcare institutions and providers, that they are they have started procuring these technologies.
Thank you, Dr. Shabir. That's very helpful. There was a follow-up question related to Pakistan. I think it goes directly, Chris, to the presentation that you made, of just maybe if you could highlight, either you or Dr. Shabir, just again quickly, maybe a few of the key points related to any challenges that you might have experienced trying to introduce MIFI and MISO to your essential drugs list. And this is a question that's coming from some colleagues in Nigeria. So if you had any challenges, maybe give a specific example, and then what did you do to address that challenge?
I would say that, sorry, Chris, if I can respond to that.
Of course, go ahead.
Yeah, so basically, I think now because misoprostol has been included in standard and guideline as a drug of choice, so now we have seen that people are now talking about the combi pack, that MIFO and MIFI combi pack should also be introduced. This is like a long way to go, but for inclusion of misoprostol is registered in Pakistan for the last 25 years, but that was for PPH. And the main stigma was that if misoprostol is broadened up, opened up for abortion use or post-abortion use, this will be misused. But we have the statements from the senior professors who are the champions that whether it is misused, it is even abused, it saves the life. So there were some champion statements coming at the national level and provincial level. Probably that has opened up the discussion that to bring, until we bring misoprostol open to access, we cannot reduce the number of morbidity and mortality. So that was one of the things. There was a challenge, like when we were scaling up from one province to the second province and then to the national level, probably the inclusion of tertiary level hospital, the mindset of senior gynecologists who are working at the tertiary level hospital, and the pressure was built from the rural level working midwives, when that voice we brought to the national level, that the experiences they have been facing with DNC and unsafe practices and pushing the women to backstreet and to be untrained providers. Probably this burden is directly on the health system that has been able to convince to include misoprostol in the National Essential List. Now, National Essential List says miso for PPH and UE and PAC also. So I think that is the most important step that government has taken. And the next step would be definitely Pakistan to introduce combi pack. That is a long way to go, but definitely there will be many challenges when we'll be starting discussions again.
And we'll be hoping to hear in the coming weeks the outcome of the WHO application to list the combi pack on their essential medicines list. And I think it's correct to say that if the combi pack gets listed at the WHO essential medicine list, it would be helpful for you in Pakistan in terms of an advocacy for that at the country level.
Yes.
Another question that,
yes.
Correct, yes. Okay, another question that has come in, I'll read. It says, from a supplies point of view, please comment on the suite of materials to address safe abortion supplies. In other words, instead of working on specific technologies in silo, at this stage of programming, we began to include medical abortion, MISO, combi pack, EVA, so electric vacuum aspiration, MVA, manual vacuum aspiration, emergency contraception, and family planning, so that a variety of contexts can be dealt with, including gestational age, level of service delivery, etc. Do we have any thoughts on the types of products or services that can be bundled? So a specific question about bundling a range of women's health or reproductive health products. For this, I was going to ask my co-chair, Natalie, if she wants to comment a little bit on this to start, and then I will address as well. I can just, Natalie, can you unmute yourself as a
Sure.
I just did, yes.
Oh, I think I just unmuted myself. Do you hear me well?
Yes. Okay.
I think this is an excellent comment and agree with it. This one from Somia about including all technologies into any kind of system. I think that's an excellent way to start an approach of introducing services. And I think there's also some thought about whether we could bundle. And I think bundling services with products makes a lot of sense. I think it's generally hard to bundle products together just from regulatory standpoint.
Well, and also not all products are needed together. But there could be a lot of waste. Is there anyone else who's on the call who wants to comment on this specific question about bundling of these products? If you want to raise your hand, I think we can unmute you. I think that's how it works. Okay.
This is John Townsend. Maybe I could just add one notion. I like the comment about not thinking about, abortion as a single event. And if we think about the woman or the client as the key feature, we ought to be thinking about offering a range of contraceptives anyway, making them accessible to women with unmet need, ensuring that they have access to emergency contraception where it's legal again, making sure that there's a range of abortion technologies that are also accompanied by providers and sites with the skills and supplies to provide a quality service. And finally, post-abortion family planning is another issue. So thinking about the continuum of care in an integrated fashion, I think, is critical in addressing this larger point about bundling.
Correct. Thank you. And actually, just as there's not a question coming in now, I did have something I wanted to raise, and I'm going to Kelly Blanchard. I'm going to call on you. I see you're on here to answer it. But one of the things that I think I've struggled with, and others that I work with around the topic of abortion, is how to talk about when we want to use the term early abortion versus later abortion. And if we're choosing to use the term later abortion when we're talking about abortions later in gestational age, are we infusing any sort of stigma willingly or unwillingly in that discussion, maybe unnecessarily? And Kelly, I know you work a lot in this area, so I was wondering if you could sort of help us think through that in terms of how we're talking about abortion and using these different terms to talk about periods of time separate from using specific gestational age weeks.
Yeah. Jennifer, can you hear me?
Yeah.
Oh, great. Thank you for that. It's really a vexing question. So in the U.S., there's been some explicit research looking, for example, at what terms resonate with people. We have wanted to avoid the term later abortion, partly, I think, Jennifer, for the reason you're getting at, which is later, it sort of suggests you're late, or you didn't come on time, or you weren't responsible, you didn't get there early, which is many people set up as better. But the challenge is that in the research, at least from the US, there are not really better general terms that resonated with people. So yeah, so there, at least at Ipas, we're largely going back to talking about weeks, also because trimesters don't mean a lot to most people. They don't know exactly what time periods they cover. And trimesters are also sort of arbitrary, right? Like the line between the first trimester and the second trimester, there's not some huge change that happens. So I think sticking with weeks is weeks or days, depending on who you're talking to and what audience, is the most precise. But of course, in some cases, that's also going to be tricky and may or may not be helpful. So I would go back to one of the points made earlier about knowing who your audience is, and if we're thinking about that, if any of us are thinking about using the terms earlier or later, just to think about whether we really need to use those terms or if there are ways to avoid setting up those two things as in conflict with each other.
Yeah, thank you. That's very important. Are there other questions? I'm looking here on our thing. I just going to open up and see if we see another. I do see one. I'll read it. The next question is, and so I'll leave it open to any of the speakers, or if someone else would like to answer, you can raise your hand. Has anyone done work specifically on abortion challenges of young women who aren't thinking necessarily about preserving family, but about their own futures and the potential impact of medication abortion? I think many, many people have done work on this. Is there one group that would like to address the work that they have done?
Yeah, we can. I can speak about it a little bit. This is Hadassah here from IPPF.
Great.
So I specifically work on a project that focuses on reducing abortion stigma amongst young people. So a lot of the resources that we've created have a clear focus around young people. And also about sort of the compounded stigma that young people face. So we know that obviously there is huge levels of stigma for any one person trying to access abortion services, but young people who are pregnant, in particular those who are unmarried, will often feel that they're stigmatized whatever choice that they make, whether they choose to move through a full pregnancy or not. So when we are thinking about young people, we've always got to think of them about them in this specific sort of group of people with different needs to potentially those older than them. And again, we know that like young people will face specific barriers, not only being stigmatized because of their age, but because of laws within countries, lack of access to quality healthcare, lack of access to information. So it might just be that they're not receiving sort of comprehensive sex education within their communities or sort of within their countries. So I would encourage you to sort of look at some of the resources that we've created and think about specifically our education guide on abortion, which is really focused on young people, and we're happy to provide any support through our project. And if you need any help sort of working on communications with materials which are focused on young people, we'd be happy to support you on that. And please, do reach out. I assume Alexandra will be sharing our contact details at the end of this as well. So please, do reach out.
Great, thank you. And are there any, I believe, here we have a note. Oh no, I think that we've answered that. That was our question from PRB, our colleagues at PRB. Are there any final questions for our speakers?
This is John. I just wanted to mention one issue that came up in discussions with IPPF affiliates in Europe. They want to know about the use of conscious objection in the denial of abortion services. And there's IPPF put together an IMAP briefing on the topic, and essentially They looked at all the court cases and the ethics and the philosophy, health philosophy related to abortion. And there are a couple, 2 or 3 points I just want to mention that people may find useful. The first is kind of the right to conscious objection is, derived from the right of freedom of conscience, and so belief and so on. But it's not an absolute right in the sense that it can't deny access to health services for others. The second thing is it's a right that only can be held by individuals, not by institutions or businesses or other legal entities. So if an organization says, no, we can't do that because our organization would like to object in terms of conscience, organizations don't have conscience. And then finally, it only applies to direct private providers and not to administrative or support personnel. So I think if you look into the literature and refer to this as well as a related statement on conscious objection by the American College of Obstetrics and Gynecology, also in 2016. The important point is that conscience operates in 2 ways. One, it may be that under conditions of legal restrictions, a provider who's given an oath to care for the health of their clients would use conscience actually as a rationale for providing care. And I think this is a rich area for discussion, then maybe a topic for another webinar. Thank you.
Mm-hmm. Thank you. Thank you very much. Well, great. Well, I think we have come up on our 1-hour time point. So I would just like to thank John and Sarah and Hadassah and Chris for their wonderful presentations and contributions, and also my colleagues, Alex, Sophia, and Natalie, for being able to get this all together, and all of you for participating. So we're delighted to be able to have this webinar that we really felt came out of some of the discussions that happened at the Kathmandu meeting. And we welcome any feedback from anyone about the webinar, the style of the webinar, the way we managed it, and also any ideas for future webinars that you would like to see this group be able to lead in the next 6 to 12 months as we start planning our work agenda moving forward. So on that note, I wish everyone a wonderful Tuesday.
Thank you very much.
Thank you.
Bye-bye.
Bye.
Thanks, everyone. Bye.